Okay, assalamu alaikum. Today we will discuss about nephrotic syndrome. أول حاجة بغيت نعرف بعدا واش كتسمعوني. Okay, let's start. Today we will discuss about nephrotic syndrome. We will discuss about definition, what does mean, and what does mean nephrotic syndrome, glomerular filtration barrier, pathophysiology, causes, diagnosis approach, treatment, question with answers. Definition. What does mean nephrotic syndrome? Nephrotic syndrome is a clinical syndrome defined by massive proteinuria responsible for hypoalbuminemia with resulting hyperlipidemia, edema, and various complications. It is caused by increased permeability through the damaged basement membrane and the renal glomerulus, especially infectious or thromboembolic. So in nephrotic syndrome, we have proteinuria, which is presence of protein in urine, which is also abnormal, like in physiology in our kidney. In normal situation, proteins does not excreted in urine. But here we have damage in basement membrane in the renal glomerulus. That's why we have loss of proteinuria. And the most important protein in our body, which is important, is albumin. So we have a massive loss of albumin or hypoalbuminemia, and we have hyperlipidemia. We will know in next pages why. And we have edema because we have low level of albumin and various complications. Glomerular filtration barrier, we have 3 layers. We have, as we see in the picture, we have glomerular capillaries, fenestrated, vascular layer with pores to selectively leak substances from the plasma of the blood to the Bowman space. Like the first layer is the capillaries or the blood vessels of the nephron, and which have pores which is selectively leak substance. They selected specific substance. يعني ماشي أي حاجة كدوز، كاينين specific substances اللي كدوز من البلازما حتى البومان سبيس. هادشي normal physiology. Second layer, which is glomerular basement membrane, negatively charged membrane adhering the capillaries, which block large proteins from passing through the FB or glomerular filtration barrier, and proteins are negatively charged. So interacting with GBM repel and prevent them from passing. As we know, we have this layer is negatively charged, and proteins also are negative in charge. So they prevent the passing of proteins from capillaries. They block the passing of protein to pass, and we have third layer, which is important for our topic, podocytes. Podocytes, like we see in the picture, they contain food processes and filtration slits to allow some degree permeability. And we have function of the glomerular filtration barrier is regulating what leaves the blood and entering the Bowman space. And we only want electrolytes, water and nutrients, and blocks the loss of red blood red blood cells, white blood cells, and proteins. But when the damage of GFB happens, we cannot regulate what leaves the blood and enter the Bowman space, which allows the passage of red blood cells, les globules rouges, et le globule blanc, et le protein. We have function ديالو هو regulating what leaves the blood and enter the Bowman space. In normal state, proteins, red blood cells, and white blood cells, which are very important for our body, like when we have red blood cells is important for blood circulation, and loss of red blood cells, it leads to various conditions such as anemia. White blood cells, they are important for like situation infections, like when our bodies present or there is a pathogen, we need our white blood cells to protect us from foreign body. And proteins, like we said before, such as albumin, which is important for osmotic pressure. Pathophysiology of nephrotic syndrome. We have normal podocytes, which consist of food processes, glomerular basement membrane, normal actin, cytoskeleton. And when they injured, like in our case in nephrotic syndrome, we have food processes effacement or flat. يعني كيكونوا مسطحين، يعني دوك البروسيسز دوك بحال تقريبا بحال دوك الرجيلات اللي كيكونوا دايرين بالبلاد فيسلز، هما اللي كنتحكمي في الفلتريشن وما كيخليوش اي حاجه تدوز. دونك ملي تيوقع لهم damage or they injured, they cannot function properly، ما كيخدموش like normal كيفاش خصهم يخدموا. دونك بزاف ديال الحوايج كيكونوا مهمين عندنا في الباديز كيدوزو نورمالمون خصهمش يدوزو. باش كيبان لينا بروتينيوريا، كيبان ريد بلاد سيلز، كتبان هيماتوريا which is presence of blood in urine. And we have pathophysiology. Podocytes are cells in Bowman capsule in the kidneys that wrap around capillaries of the glomerulus, such like we see in the picture, which play an active role in preventing plasma proteins from entering the urinary and ultrafiltrate by providing a barrier compressing filtration slits between food processes. Injured podocytes lead to lose the capacity to control what's leaving the blood and entering the Bowman space, causes massive amount of protein loss, or in medical term, proteinuria. When podocytes damage, effaces the food processes of podocytes, which is called podocytes effacement, and becomes flat, lead to losses regulating functions, and leads to heavy degree of proteins loss, proteinuria across the glomerular filtration barrier. Okay, when we have proteinuria equal or more than 3 gram per day of protein loss in the urine is one of the hallmark sign of nephrotic syndrome. When we have, like we said before, the massive amount of proteinuria, like equal or more than 3.5 gram per day, it's a hallmark. It's like we know that this patient have nephrotic syndrome. Okay, we have hypoalbuminemia, and we have recall. That's albumin recall. يعني like احنا كنعرفوا اصلا في العاده بان الالبومين maintain oncotic pressure but decreases the level of albumin causes various problems. We know الالبومين في normal function they كيحافظ لنا على توازن ما بين الماء اللي كيدوز لنا في cells between cells in blood vessels. الالبومين نورمالمون كيكون في البلاد في لو سون، ملي هو اللي كيتحكم لينا في الواتر ملي كيدوز وكيمشي. دونك هو اللي كياخذ لينا الواتر من السيلز، ملي ما تيبقاش يخدم كيكون ناقص الواتر كيبقى لينا في السيلز وكيدير لنا إديمة. Like we see here in the table, we have edema, we have albumin decreases in blood in blood in efferent arterioles, which lead to decrease oncotic or osmotic pressure, decreases the ability to draw water from cells, and fluid stay in interstitial space, causes edema. And we have lipid production. In response to low albumin, the liver tries to synthesize albumin, but at the same time produces lipoprotein, like a very low density lipoprotein or low density lipoprotein, which causes high triglycerides and high cholesterol. ملي كيكون الالبومين ناقص عندنا بزاف، الليفر ديالنا والفوا كيحاول انه يعوض هذاك النقص ديال الالبومين، وفي نفس الوقت ملي كيحاول يخرج لنا الالبومين، في نفس الوقت كيخرج لنا حتى اللايبوبروتينز. And we have RAS system, which is renin angiotensin aldosterone system. We have low osmotic pressure, which leads to low fluid in blood vessels, effective arterial blood volume, which sends signals to the kidney that there is low perfusion, stimulate RAS system, the renin angiotensin aldosterone system, and then causes hypertension, sodium and water retention, lead to edema. RAS system activation ملي كيكون عندنا osmotic pressure ناقص كيحفز لينا الفلويدز ان بلاد فيسلز، كينقص لينا الفلويد الليكيد اللي كيكون في البلاد فيسلز في البلاد فيسلز ديال الارتيريال فوليوم، اللي بدورو هذا النقص هذا كي بحال كيدير سيغنال، كيعطي الاشاره للكيدنيز ديالنا لغا بانه راه كاينه لو برفيوجن، اللي كيحفز لينا انه الجسم ديالنا كيحاول يعوض هذاك النقص ديال البلاد ديال الليكيد اللي عندنا في البادي ديالنا، وكيحاول يطلع لينا التونسيون راس by renin angiotensin aldosterone system, and which result in hypertension, sodium retention, lead to edema. We have two عندنا إديمة كتوقع لينا بجوج ديال الحوايج، إديمة كتكون من نقص ديال الألبيومين، وإديمة ملي كتوقع لينا اللي كيطلع لنا الهايبرتنشن. الهايبرتنشن صوديوم اند الواتر ريتنشن، هو نورمالمون كيحاول أي بلاصة فيها الصوديوم والماء كيجرو وكيدير لنا إديمة. You have decreased antithrombin 3. Recall antithrombin 3 is an anticoagulant, but when it's low, the high level of thrombin will result in increased clot formation. Venous clots, normally thrombin is a procoagulant, stimulate clot formation, which result in deep vein thrombosis or renal vein thrombosis, which is infection, like most common thing. حاجه اللي كتكون كثيره في الكيس ديالنا في نيفروتيك ساندروم، ملي كيكونوا الإيمونوغلوبين نازلين، اغلبيه كتكون ستريبتو pneumonia is the most common pathogen, which increases the risk of community acquired pneumonia. We have causes. We have primary causes and secondary causes. Primary causes are idiopathic. We don't know why they happen, and we have three examples: minimal change disease, membranous nephropathy, and focal segmental glomerulonephrosis. And secondary causes, there is already a cause, and they are like secondary cause. We know the cause why this condition happened, but primary we don't know. Secondary causes, we have diabetic nephropathy because of high level of glucose, and amyloid. We have sclerosis, like we will see in next pages. Primary causes, we have minimal change disease. It's idiopathic. We don't know why it's like congenital. We don't know why that happened. We don't know the cause. It's most common in children. Secondary causes, infection, Hodgkin lymphoma, which is type of cancer that affects the lymphatic system, which is part of the body germ fighting immune system, or non-steroidal anti-inflammatory drugs. Mechanism: T cells go to the kidney to release cytokines, which damage the podocytes, cause podocytes effacement, result in proteinuria and lipiduria. Okay, we have minimal change disease. We have two things. We have idiopathic, we don't know why, and we have secondary causes. The patient may complain of from infection, Hodgkin lymphoma, or non-steroidal anti-inflammatory drugs. The mechanism, it's the T cells. The T cells go to the kidney. T cells, which is cell of our immunity, go to the kidney, les reins, to release cytokines. الحاجه اللي كدير لنا الدمج كتهرس لنا البودوسايتس اللي قلنا في الاول بانها عندها فود بروسيسز اللي مسؤوله على الفلتريشن، ما كتخليش البروتين انه يدوز. Causes podocyte effacement, result in proteinuria and lipiduria. Membranous nephropathy, we have primary cause, antiplatelets receptor antibody, and we have secondary cause, hepatitis B, hepatitis C, syphilis, gold, and penicillamine. Mechanism: it's antibody antigen complexes or antibody deposits to the subepithelial layer, which trigger an inflammatory reaction, activate complement protein like C3 and C4, result in podocytes effacement. We have third phase, which is focal segmental glomerulosclerosis. We have primary cause idiopathic, we don't know. The secondary causes HIV, sickle cell disease. Mechanism: sclerosis and hyalinosis. كتجيب وحده ما كنعرفوش السبب علاش جات of parts of the GFB, which result in podocytes effacement. نفس الحاجة، نفس الميكانيزم كتختلف ولكن الريزلت كتكون نفسها. Note: focal segmental glomerulosclerosis and membranous neuropathy can damage the kidney if untreated and can progress to chronic kidney disease. As for minimal change disease, it does not usually cause chronic kidney disease. We have three types of primary causes. الأولى اللي هي اللي قلنا أنها common in children، ما كديرش لنا chronic kidney disease. ولكن second تانيين focal segmental and membranous nephropathy كيقدروا يديو لنا إلا ما تكتشفوش قبل، إلا ما تخداش تريتمون، يقدر يدير لنا chronic kidney disease، ويقدر يوصل لنا حتى ل kidney failure. B, we have secondary causes. We have two types. We have diabetic nephropathy. We have already known that the glucose level is high in diabetes mellitus, which causes non-enzymatic glucosylation, which is excessive chemical attachment of glucose to proteins without the involvement of enzymes. Among the mechanisms by which hyperglycemia may lead to tissue damage of the efferent arterioles, also called efferent arteriole hyaline arteriosclerosis, makes it impossible for blood to leave glomerulus and result in very intraglomerular blood pressure and increase glomerular filtration rate. As a result, there is GBM thickening and sclerosis in nodular pattern. Podocyte food processes which are similar to podocyte dysfunction. The same result. Podocytes ما تبقاش دير لينا الفانكشن ديالها. Sclerosis and nodus can progress chronic kidney disease. The most common cause of chronic kidney disease is diabetic nephropathy. Diabetic nephropathy normally in diabetes mellitus. في الديابيت كيكون عندنا الجلوكوز طالع لينا بزاف، وكي accumulate كيتجمع لينا الجلوكوز في في الجلوميرولس، وكيخلي انها ما كتبقاش البلاصه ديال البلاد انه يدوز لو سون، دونك كتخلي لينا makes impossible for blood to leave. بحال كدير vasoconstriction leave in very high intra كتخلي انه تحت ضغط كبير وما كتخليش و increases glomerular filtration دونك كتبقى تصفي لينا بزاف حتى كتولي تخرج لينا كلشي الحوايج اللي بغينا الحوايج اللي ما بغيناش كيخلي انها ثيكنين انها كتغلاط سكليروسيس وفي الاخر راه البودوسايت ما تبقاش دير لينا الفانكشن ديالها وكتقدر تؤدي لينا حتى هي الكرونيك كيدني ديزيز. Second type of secondary causes, which is amyloid nephropathy. Mechanism: the body produces abnormal proteins which deposit into glomerular filtration barrier and causes thickening of GBM and sclerosis, result in podocyte processes stretch out. This can lead to chronic kidney disease. We have two types. We have amyloidosis AL and AE amyloidosis. First one involve light chain amyloid proteins, like when we do microscopy. We can see this light chain, and it can be seen in multiple myeloma. And you have hypercalcemia, renal failure, anemia, bone pain. We have secondary amyloidosis seen in rheumatoid arthritis, increases inflammation and production of amyloid proteins. For diagnostic, we have history and physical exam feature can help in the diagnostic approach: edema, history of recurrent deep venous thrombosis, renal vein thrombosis, increased risk of infection. When we have patient, we can ask them some question if they have the same pathology in their family, or like they have in the last days or last week, if they complain from edema or they have history of this renal vein thrombosis, or if they have high risk of infection. Okay, for diagnostic, we can use urinalysis and microscopy. Urinalysis in microscopy can differentiate between nephrotic and nephrotic syndrome. DEB6, DEB6 or bonded urinaire in French, does not quantify protein loss as much, but to give you an idea. In nephrotic syndrome, the DEB6 may show +1, +2, +3, but it is not good at quantifying blood loss. في اليوريناليسيس ملي كنديرو البوندليت يورينير كناخدو واحد السامبل واحد اليورين ديال بيشن وكنديرو ليه بوندليت يورينير وكنشوفو دوك لي كارون دوك المربعات كنشوفو واش عنده البروتين شحال واش عنده +1 +2 +3 كيقول لنا غير واش عنده انه بروتين ولكن ما كيقولش لنا الكميه شحال ديال البروتين خصنا نديرو another tests. And we have sterile pyuria, which is high level of white blood cells in urine without the presence of bacteria. داكشي علاش سميناها sterile pyuria. We have white blood cells كاينين في اليورين ولكن ما عندناش infection. عندنا غير على قبل هاد السيندروم اللي عندنا هي اللي كدير لنا الوايت بلاد سيلز ولكن without infection. Okay, we have nephrotic syndrome and nephrotic syndrome, pathophysiology and the results. Inflammation of في الباثوفيسيولوجي ديال nephrotic syndrome, we have inflammation of glomerulus and podocytes which result in podocyte damage, result in high amount or massive loss of proteinuria and high level of lipiduria, and we can see fat oval bodies. كيبانوا لينا واحد circulation كتبان لينا واحد الاوفال كتبان لينا واحد دوائر ديال الفات ليبيدز كنشوفوهم في اليورين كنشوفوا البروتينيوريا وكنشوفوا الليبيديوريا. في النيفريتيك سيندروم عندنا باثوفيسيولوجي اخرى عندنا الانفلاميشن of glomerulus cause GBM damage result in loss of red blood cells, white blood cells, proteins. في في النيفريتيك ماشي بحال النيفروتيك عندنا بزاف ديال الحوايج كيبانو ماشي حاجه وحده. في الباثوفيسيولوجي ديال النيفروتيك كيكون عندنا بزاف لوس ديال بزاف ديال البروتينز، كيكون باين بانه عنده ماسيف لوس اوف بروتين. ولكن في النيفريتيك عندنا ريد بلاد سيلز اللي كتبان لينا لايك هيماتوريا، وايت بلاد سيلز هما كيبانوا لينا في اليورين without infection غير بيكوز ديال السايندروم اللي عندنا. وعندنا البروتين ما كيكونوش طالعين بزاف بحال الكيس ديال نيفروتيك سايندروم. في الريزلت we have high proteinuria ولكن ماشي massive، ماشي بحال nephrotic syndrome. We have hematuria because presence of red blood cells. We have pyuria sterile and we have red blood cells casts. 24 urine or urine albumin creatinine ratio, also called spot urinalysis. It gives the amount of protein loss in 24 hour. We can ask the patient to save their urine for 24 hour, and after that we can differentiate between nephritic and nephrotic. Like in nephrotic, we have massive proteinuria equal or more than 3.5 gram per day. And we have in nephritic we have proteinuria ولكن ماشي بزاف، كتكون قل من 3.5 gram per day. And if we have proteinuria equal or more than 3.5 gram per day, lipiduria, no hematuria and pyuria, you're likely to have nephrotic syndrome. If you have hematuria, pyuria and proteinuria, it's more likely nephrotic syndrome. Albumin and lipid level. We have there is high albumin loss in nephrotic syndrome, hypoalbuminemia, and low serum albumin, and we have high lipid as compensation lipoproteins such as VLDL and LDL and triglyceride, and there are feature of hyperlipidemia. وكيش يكون عندنا high level ديال albumin، كيكون عندنا albumin طالع بزاف في اليورين ولكن ناقص عندنا حنايا في النيفروتيك سايندروم. وعندنا اون باراليل معها كتكون هايبرليبيديميا as compensation. لو فوا كيحاول انه يعوض لينا داك الالبومين اللي ناقص وكيخرج لينا الليبيدز معاه lipoproteins. We can do renal biopsy if there is an unclear cause of nephrotic syndrome. إلا ما لقيناش السبب ديال هاد النيفروتيك سايندروم، آخر حاجة كنديرو هي renal biopsy. Rate to perform kidney biopsy for amyloid and diabetic nephropathy and in children because we have already الحوايج اللي ديجا عارفين الكوز ديالها، كنتريتيو كان just treatment ديال الكوز ديالها وصافي. ملي كنديرو البايوبسي هي الاند ستيج ملي ما كنعرفوش الكوز. and in children in less بعدا renal biopsy is contraindicated in pediatrics in children قل من 10 سنين. And we have like for histological examination we have 3 methods. We have light microscopy, which gives us general look at the glomerulus, and you have electron microscopy, zooms in on podocytes. And we have immunofluorescent look for and we have immunofluorescent look for antibody or immune complex deposition look for fluorescent green. اوكي we have هاد التيبل هذا كيورينا الهيستولوجي شنو كنشوفو في الميكروسكوب. we have MCG في اللايت مايكروسكوب نورمال ما كيفيدنا حتى شي حاجه. الكترون مايكروسكوب كنشوفو البودوسايت افيسمنت. في immunofluorescent نورمال. في membranopathy nephropathy we have thick GBM, and في electron microscope we have effacement of podocytes and subepithelial deposition. And in immunofluorescent, we have granular appearance of subepithelial immune complex deposits. And diabetes, for diabetes nephropathy, we have nodular sclerosis in glomerular space. And amyloid nephropathy, we have flight microscope nodular sclerosis. And electron microscope, we have amyloid fibrils with apple green Bayer fringes and on Congo red stain, which is stain of amyloid. And we have FSGS, focal hyalinosis, sclerosis, light microscope. And electron microscope, we have podocytes effacement. Treatment for proteinuria can do increase the protein diet. We ask the patient to decrease the proteins and ASE inhibitors or RBCs if blood pressure tolerates. Patient with nephrotic syndrome may also have hypertension from stimulation of RAS system. SA inhibitor can inhibit لنا هذا الباثوي اللي كان قدام جينا هنا increases antithrombin 2, increase intraglomerular blood pressure, increase GFR, increase protein loss. ACE inhibitor كي من عندنا هذا الباثواي كله. Therefore, giving ACE inhibitor or RBCs angiotensin receptor blockers prevent high antithrombin 2 and then prevent increases EGFP and GFR and protein loss. And for hyperlipidemia, we have diet changes and statin. Diet changes كيبدل لنا ما كياكلش شي حاجة فيها الدهون cholesterol or any else. We have statins, which is the rate limiting enzyme in cholesterol biosynthesis pathway. For edema, fluid and sodium restriction, the diuretics if fluids and sodium restriction does not work. We have hypercoagulative state. We can prescribe anticoagulation, but this patient have risk of renal vein stenosis. And we have for high infection risk, pneumococcal vaccination decreases edema, which can increase the infection. Treat the cause of nephrotic syndrome. Secondary causes of nephrotic syndrome, treat the cause. Primary causes of nephrotic syndrome, we have minimal change disease, good response to steroids كيستجيبوا ليه بسرعة، ولكن السكند الآخرين لا are poor to response to steroids. دونك كيكون عندهم long term of immunosuppressive drugs. Secondary cause, we have treatment, get rid of non-steroidal anti-inflammatory drugs, treat the infection, treat Hodgkin lymphoma. And for MN, it's treat hepatitis B, hepatitis C, or syphilis. We can just treat the cause of this condition. Primary causes, we have MCD, MN, or FSGS. Recall that cause is idiopathic and is likely genetic or autoimmune. Steroids, all these conditions should start on steroids to suppress the immune response. Good response, as we said before. Poor response, minimal change disease with a good هما كيستجيبوا لنا steroids. دونك نقدروا نتفاداو البيوبسي ما كنديروهاش. Membranous nephropathy, they are poor response ما كيستجيبوش لنا الستيرويدز. And we can do biopsy in this case. Okay, we have question. What is the main pathophysiology of nephrotic syndrome? As we said before, we have the main cause or the main symptoms which causes proteinuria, and this all of the symptoms. It's podocyte dysfunction. It's B. And second question is edema is caused by the following. We have decreases osmotic pressure in the blood, and we have also stimulation or activation of RAS system. which causes nephrotic syndrome does not result in ECRD. We have three choices. We have focal glomerulosclerosis, diabetic nephropathy. It's more likely D. It's GNS. And fourth one is which cause nephrotic syndrome response to greatly steroids is first minimal change disease. الديزيز اللي كتكون idiopathic وكتكون more in children, they have a good response to steroids. Okay, thank you. I hope that أنكم استفدتوا وحاولت ندير ما أمكن وميرسي شكرا.